Thank you very much for the introduction, and thank you to the Society for letting us present this talk. I just want to say up front, this is a review of a trial that finished 2 years ago, and it's a 24-month follow-up of a phase 1 study. The authors of the study are listed there. I was not an author of the study, but was asked to present this study on their behalf since they could not come to the meeting here. There we go. As just quick disclosure, I was a co-founder of Profound Medical. This is back in 2008, and I also have conducted academic treat and resect clinical trials with an academic version of the system in the early years before this trial. So, as an introduction, again in the 5-minute time span, MRI-guided transurethral ablation involves inserting a HIFU device through the urethra, so a little bit different approach from the transrectal devices we saw earlier. The device involves a series of planar transducers with directional ultrasound beams, just point them out, which produce a collimated heating pattern, and that coupled with device rotation allows energy to be distributed through the prostate gland for a conformal heating pattern. So it's a sort of an inside-out approach. It's a minimally invasive treatment, just as transrectal HIFU is for prostate tissue ablation. Some differences, I guess, to help put it in context. From the beginning, this technology was developed to be used in the MRI, so it's a truly MR-guided and controlled technology that allows, precise treatment planning that MRI offers. It also enables in treatment control using temperature feedback, so all the things we're familiar with from MR-guided HIFU. And perhaps another interesting difference, which really arises from the fact that all the energy is being deposited continuously. There's no waiting. It takes approximately 45 minutes to treat a large prostate gland. So time might be one of the interesting advantages of this technology. Just graphically, to contrast the differences, this is just 2 views of the prostate, just showing conceptually, again, the inside-out approach of a transurethral treatment versus the transrectal approach. You can see how the heating patterns are different in size and shape, and of course, when we do the treatment, one is in the transrectal case, we're doing sequential lesions to build up a volume of ablation. With the transurethral approach, it's a sweep and a continuous ablation. And the technology is very portable. It's just a device that is inserted in the urethra and a small footprint to be inserted to be attached to a table of an MRI. And so for that reason, this technology, through our early academic work and now commercially, has actually been used on all MR platforms, which is quite unique for a lot of our MR-guided HIFU technology. We evaluated it in a GE platform initially, then Philips, and commercially it's been used on Siemens and soon to be Philips as well. So it's unique in that regard and maybe similar to some of the laser technologies that are out there that are used on all MR platforms. So this is there was a phase 1 clinical study that was sponsored by Profound Medical. The investigators were listed on the first slide. It was across 3 countries listed there. 30 patients were enrolled. You can see the dates of the trial, completed in 2014. Primarily low-risk prostate cancer patients with a few intermediate risk patients who were primarily in Canada. And the primary endpoints were safety and feasibility for a phase 1. With 1-year follow-ups, and there were some exploratory endpoints looking at PSA, biopsy, quality of life, and those were followed up for 5 years. The technology was the Profound Medical TULSA Pro system on a Siemens 3T platform for this particular study. This was a conservative whole gland ablation. What that means is, by trial design, the target boundary of treatment was approximately 1 millimeter from the boundary of the prostate gland, which left volumetrically about 10% of the gland untreated, and that'll come back up at the end. And that was, again, by trial design for this first safety study. It was done under general anesthesia in an MRI, and GI antispasmodic drugs were administered, and a suprapubic catheter was left in place and removed at 2 weeks. Many more details I'm not covering. I have a picture and a reference below of the trial results that were published just recently in European Urology, and I encourage you to look into more detail there. Oops, I'm sorry. So the data that's new here is really looking at 24-month follow-ups, and you can see here a timeline of a number of measures: PSA, erectile function, prostate symptoms, and urine flow. The take-home message really is that PSA reductions seem to have been durable through 24 months. Initial transient effects at 1 month that could be seen with erectile function and urinary symptoms. what seemed to have been returned to normal at 12 months seems to have held through as well at 24 months. So it seems to be a durable response that was in terms of return to normal function and PSA reduction. These initial results were all from the early response. They haven't changed in terms of the rate of grade 4, 1, 2, and 3 adverse events. Excuse me. There we go. Oh, too sensitive. Sorry. Okay, here we go. And so finally, just in terms of, this is again all published in the study, but just to go to it, the treatment resulted in an 88% median prostate volume reduction. So a large volume reduction, which is probably seen as well with transrectal HIFU. One surprising finding was the positive biopsy rate, which was high in this first group of patients. And when I discussed this with the authors and also discussed in the paper, this was attributed to the phase 1 parameters being very conservative with viable prostate expected, in fact, at the prostate periphery. And so in parallel, our group in Toronto at Sunnybrook Research Institute was running a treat and resect study where we were escalating the boundary temperatures that we were treating to in a small group of men and looking at what parameters we found necessary to reach the capsule of the prostate from this, again, inside-out approach from the urethra. We found that about a 57 degrees Celsius, so a few degrees higher than what we found earlier, was really necessary to achieve that complete ablation as shown here. And so really the summary here, just one more time. There we go, is that this first experience with this system from Profound, the TULSA Pro, demonstrates that it's clinically feasible. The data suggests it has a low toxicity, good safety profile. And so the next phase is to finish this phase 1 and follow up men to 5 years. And a pivotal study has recently been approved by the FDA and is essentially underway in terms of setting up sites. It's approximately 100 patients, and there's a description of the trial in detail on clinicaltrials.gov. And finally, the endpoints of that trial will be ablation, efficacy, safety, and biopsy. And some key differences I think worth mentioning is that inclusion into this will be a diagnostic multiparametric MRI, and also this increase in target temperature to get complete whole gland ablation. Thank you.
In terms of tissue sloughing or any encounter, in terms of how long does it take for the tissue to resorb?
I had that discussion with the authors, and I think they talk about that in the paper. Basically, they had a suprapubic catheter, which I think is slightly different than some of the transrectal talks we heard with Foley catheters. But I think after about 14 days, in all cases, they had returned to urine flow and urine function. Mm-hmm. So some initial swelling.
You have a question?
Yeah, kind of, I guess 3 questions, maybe all in one. The first is, since you're treating inside out, have you noticed, I guess, periurethral cavitation, and if that's impacting your ability to heat in the periphery of the prostate? The second was, have you defined what your criteria for biochemical recurrence will be on these patients as they move on longer term? And now I forgot the third question, so I'll settle for that.
I can answer the first one because I have a technical background. I'll defer to the clinicians and the users of the technology for the second one in terms of PSA, biochemical recurrence. I think that'll be probably learned as this technology gets used. But in terms of the cavitation, that's an important technical question. I would say that the frequencies here are around 4 megahertz, and there's actually a dual frequency approach and some higher frequency treatments of 14 megahertz. But anyways, they've been chosen to avoid boiling. And also the MR thermometry allows, and there's part of the treatment is to monitor the temperatures in the region close to the urethra to avoid any temperatures that would be in the boiling category. But because it's a higher frequency, risk of cavitation, as you might expect at low frequencies, is a lower risk. It's really boiling that's the concern. And yes, if that does occur, it can affect penetration. The treatment, attempts to eliminate that or to, not have that happen.
I think your second question is an excellent question, especially as there's a move toward less than whole gland therapies, where we know we're going to have PSA levels and close to, perhaps even close to pre-treatment levels, especially with focal therapies. How are we going to identify recurrence? Does that mean that there's a larger role for imaging? And just how are we following up these patients? I think is a critically important question. As this area moves along rapidly, we have to address those questions just as well.
I completely agree. Thanks.
Thank you.